Diffuse parenchymal lung diseases, or DPLDs, are a group of rare lung disorders that affect the interstitium of the alveolar wall, the alveoli, as well as the blood vessels and the pleura of the lungs. Previously, they were called interstitial lung diseases because we thought that they only affected the interstitium. Now, there are literally hundreds of DPLDs out there, so it's more important to know how to classify them based on their key features than to memorize the names of an ever growing list of diseases. DPLDs can be broadly classified into those with a known cause and those with an unknown cause, which are also called idiopathic. DPLDs that have a known cause can be subclassified into connective tissue diseases like systemic lupus erythematosus, rheumatoid arthritis, or systemic sclerosis, occupational exposures like asbestosis, silicosis, and berylliosis, granulomatous diseases like sarcoidosis and hypersensitivity pneumonitis, and treatment-induced causes, like the antiarrhythmic amiodarone, the antibiotic nitrofurantoin, the chemotherapeutic agents methotrexate, bleomycin, and busulfan, as well as exposure to radiation. Now, idiopathic DPLDs include many subtypes, but the most important one is idiopathic pulmonary fibrosis. In all scenarios, tobacco smoking can potentially worsen an existing DPLD. Now, DPLDs are classified in this way because the known causes are often more treatable and relatively reversible compared to the idiopathic causes. Consequently, when approaching an individual, it's crucial to first think through the known causes. Additionally, it's important to understand that DPLDs are rare and that other causes of respiratory symptoms like pneumonia and heart failure should be considered. Alright, now regardless of the cause, DPLDs share similar clinical, radiographic, and pathological manifestations, which is why all these diseases are clumped under the DPLD umbrella. Individuals with DPLD commonly present with shortness of breath that worsens with exertion and a dry cough over the course of months to years. But these are still broad symptom categories, so thinking through other clues can help. Think of connective tissue diseases if there's a woman in her 30s. A history of occupational exposure may also clue to an occupational lung disease, such as asbestosis in a shipbuilder, berylliosis in an aerospace engineer, silicosis in a sandblaster, or hypersensitivity pneumonitis in a farmer exposed to bird droppings. If an individual also has joint pain, think of rheumatoid arthritis. Or go a step further and think of the methotrexate that's being used to treat their rheumatoid arthritis. On examination, crackles may be heard on auscultation, and clubbing of the fingers may occur due to chronic hypoxia. A loud pulmonary component of the S2 heart sound may be heard, and this could indicate pulmonary hypertension, which can occur secondary to chronic hypoxia. Blue discoloration of the skin and enlargement of the thyroid gland may indicate long-standing amiodarone use. Swelling of the parotid gland, facial palsy, uveitis or conjunctivitis, restrictive cardiomyopathy or heart block, and erythema nodosum are all extrapulmonary features of sarcoidosis. Violaceous discoloration around the eyelids, called a heliotrope rash, and purplish papules on the knuckles, called Gottron's papules, indicate dermatomyositis, while a red malar rash across the nasal bridge suggests lupus. When a DPLD is suspected, the best initial test is a chest X-ray, which usually shows nonspecific interlacing web-like reticular infiltrates, or spherical nodular infiltrates, or a combination of both, called a reticulonodular pattern. And then after a chest X-ray, the next step is a high-resolution computed tomography, or HRCT scan. The HRCT gives more anatomical detail than the plain X-ray, and may show specific manifestations. For example, bilateral hilar adenopathy may indicate sarcoidosis. Upper lobe calcified nodules called eggshell calcifications are characteristic of silicosis. In idiopathic pulmonary fibrosis, the alveolar walls become so thick that the lung parenchyma gives the appearance of a honeycomb. Pleural effusions may be seen in connective tissue diseases. Also, a linear pleural plaque, which is a thick, white elevation of the pleura that may be calcified, points towards asbestosis. Alright, now pulmonary function tests always show a restrictive pattern in DPLDs, and this helps distinguish the disease from an obstructive disease, like COPD or asthma. The most important PFTs are the forced vital capacity, or FVC, which is the maximum amount of air the person can breathe out after maximum inspiration, and the forced expiratory volume in the first second, or FEV1, which is the maximum amount of the air the person breathes out in the first second. In DPLDs, the FVC decreases. However, because there's no airway obstruction, the FEV1 doesn't decrease as much. So, the ratio of FEV1 to FVC will be normal, or even high. Also, because the lung is stiff, the lungs don't expand properly, so the total lung capacity, or TLC, and the residual volume, or RV, are decreased. Finally, because the alveoli are affected, gas exchange is impaired. Gas exchange can be tested by measuring the DLCO, which involves allowing the individual to inhale a small amount of carbon monoxide and seeing how well it diffuses. In DPLDs, the DLCO is decreased. Now, some additional labs may be obtained when suspecting a specific DPLD. For example, anti-nuclear antibodies, or ANA, and rheumatoid factor can be obtained when suspecting a connective tissue disease. In cases of sarcoidosis, granulomas secrete angiotensin-converting enzyme, or ACE, causing elevated ACE levels. Additionally, these granulomas ectopically produce a ton of vitamin D, causing hypercalciuria as well as hypercalcemia. If persistent, this may result in kidney stones and deposition of calcium in the kidneys, a condition called nephrocalcinosis. Now, these findings can help support the diagnosis. However, they are nonspecific because they can be found in various granulomatous processes. Now, in certain cases, a bronchoalveolar lavage, or BAL, may assist with the diagnosis. A BAL involves inserting a bronchoscope into the individual's airway all the way down to the smallest branches of the lung. Then, a suction tube aspirates a sample of alveolar cells from where we think the pathology is happening. The sample can then be sent off for laboratory testing, including cell counts, cultures, and cytology. Now, when it comes to DPLDs, BAL can be useful to look at the cell count. For example, in both hypersensitivity pneumonitis and sarcoidosis, the BAL lymphocyte count is elevated. These two can be differentiated from each other by looking at the ratio of CD4 positive lymphocytes to CD8 positive lymphocytes. In hypersensitivity pneumonitis, this ratio is decreased and is usually less than 1. On the other hand, the ratio is increased in sarcoidosis, usually being more than 2. Now, more often than not, DPLDs are diagnosed based on clinical signs and symptoms along with the radiographic evidence. However, because DPLDs are clinically similar to one another, sometimes it's necessary to remember that tissue is always the issue. In other words, if the diagnosis is clinically unclear, then the most accurate test to diagnose any DPLD is a lung biopsy. For example, sarcoidosis, hypersensitivity pneumonitis, and berylliosis show non-caseating granulomas on biopsy, whereas in asbestosis there are barbell-shaped mineral dust particles called asbestos bodies, and idiopathic pulmonary fibrosis shows collagen deposition within the alveolar interstitium. The treatment of DPLDs depends on the underlying cause. Individuals with occupational lung disease are advised to avoid the occupational environment, as well as quit smoking to prevent compounding the lung damage. Asbestosis is followed up for the potential development of bronchogenic adenocarcinoma, or mesothelioma, especially if the individual was exposed for more than 30 years. In fact, bronchogenic adenocarcinoma is the most common type of lung cancer associated with asbestos exposure, not mesothelioma. Individuals with silicosis are highly susceptible to tuberculosis because silica impairs the formation of phagolysosome, allowing Mycobacterium tuberculosis to survive within the cell, and so they're screened annually using a tuberculin skin test. Because berylliosis induces formation of a granuloma, individuals may benefit from the anti-inflammatory effect of corticosteroids, in addition to avoiding exposure to beryllium. Hypersensitivity pneumonitis is also primarily treated by removing the offending agent, which is often a bird. In severe cases, corticosteroids are also used. Now, if an individual with sarcoidosis is asymptomatic, then the patient doesn't need treatment and can be observed. In fact, most of these individuals completely recover from their disease in approximately 2 years. On the other hand, in cases of symptomatic sarcoidosis, oral corticosteroids are the treatment of choice. If they're not responding to corticosteroids, then azathioprine and eventually cyclophosphamide can be used. With regards to idiopathic causes of DPLDs, their treatment is primarily supportive, including maintaining oxygenation with supplemental oxygen, but only if they're hypoxemic. Interestingly, because idiopathic pulmonary fibrosis is a fibrotic disease, 2 new agents that prevent fibrosis are being used. These include the tyrosine kinase inhibitor nintedanib, which blocks fibrogenic growth factors and inhibits fibroblasts, as well as pirfenidone, which regulates transforming growth factor beta, or TGF-beta, a cytokine thought to be involved in fibrosis. Ultimately, individuals with idiopathic pulmonary fibrosis often require a lung transplantation. Alright, as a quick recap, DPLDs can be classified into those with a known etiology, like occupational lung diseases and connective tissue diseases, and those with an unknown etiology, like idiopathic pulmonary fibrosis. The first investigation is often a chest X-ray, followed by high-resolution computed tomography, or HRCT scan. These tend to show reticular, nodular, or reticulonodular patterns. If needed, either a bronchoalveolar lavage or lung biopsy can be performed to confirm the diagnosis. DPLDs with a known etiology are often reversible, while those with an unknown one are usually treated supportively.